Treatment of allergic rhinitis consists of allergen avoidance measures and pharmacotherapy or immunotherapy. Pharmacotherapy consists of oral and intranasal antihistamines, intranasal and oral corticosteroids, intranasal decongestants, antihistamine decongestant combinations, leukotriene receptor antagonists, anticholinergics, chromolins such as disodium chromoglycate and omalizumab. Other things is being allergen immunotherapy. What are the salient features of treatment for allergic rhinitis? Based on the area guidelines, you have to decide which antihistamine to choose and what other medications to be chosen. In mild intermittent allergic rhinitis, you give non-sedating second generation oral antihistamines alone. In mild persistent or moderately severe allergic rhinitis, you start with an intranasal corticosteroid alone, and if the symptoms persist, you add on a nasal irrigation such as a saline irrigation. You can add a decongestant or ipratropium. Add saline irrigation whenever required to reduce the allergen volume. You can add a decongestant when there is nasal obstruction. Intranasal antihistamines can be added. If the symptoms still persist, consider giving SLIT or SCIT. In severe allergic rhinitis, you have to give a combination of intranasal corticosteroid along with oral antihistamine, and you can add oral leukotriene receptor antagonist, and intranasal chromolins can be added. If the symptoms still persist, definitely he or she is a candidate for SCIT or SLIT. Pharmacotherapy. What are the oral antihistamines? Why and they should be given? A basic knowledge of the antihistamines is very important. Histamine is one of the main substance, it is a mediator of allergy, which is released by the mast cells and contributes to most of the symptoms such as itching, sneezing, congestion and rhinorrhea. Second generation antihistamines include cetirizine, levocetirizine, desloratadine, loratadine, fexofenadine and bilastine. Intranasal steroids, there are a few molecules such as mometasone, fluticasone propionate, fluticasone furoate, most effective being the fluticasone furoate. Mometasone is more suitable in children. Oral steroids have a role in certain situations when the allergic symptoms are extremely severe or when the patient has extensive nasal polyposis. Prior to surgery, you give a shot of oral steroids to control the disease and the inflammation. Intranasal antihistamines such as azilastine and olapatadine, they give additional benefit when added to an intranasal corticosteroid. Inhaled intranasal decongestants such as oxymetazoline and xylometazoline, they relieve the nasal congestion, which will be very troublesome for many people. However, it cannot be used in the long run for the fear of developing rhinitis medicamentosa. Leukotriene receptor antagonists such as montelukast is used in controlling some of the symptoms of bronchial asthma. Intranasal anticholinergic agents such as ipratropium bromide acts by reducing the glandular secretion in the nasal mucosa and it has minimal side effects. Chromols such as disodium chromoglycate, it is a mast cell stabilizer, it inhibits the degranulation of mast cells. Immunomodulators such as omalizumab are anti-IgE antibodies which are monoclonal antibodies. They are approved only in the USA and they are very effective when used along with allergen immunotherapy. This is a chart showing comparative efficacy of drugs. Oral antihistamines have a very good role in controlling sneezing, itching and rhinorrhea, whereas nasal congestion is not so well addressed. Intranasal antihistamines control sneezing and itching, whereas they are not so effective in relieving congestion and rhinorrhea. Whereas intranasal steroids, corticosteroids have a very good role in controlling sneezing, itching, congestion and rhinorrhea. Therefore, they score over many other medications in terms of their efficacy. Immunotherapy has gained popularity in the last couple of decades. It was introduced by Freeman in 1911. There are several routes of administration of immunotherapy. Subcutaneous immunotherapy is accepted, whereas sublingual immunotherapy is slowly gaining popularity. It is not yet fully US FDA approved. Inguinal lymph node immunotherapy and transcutaneous patches are described but not practiced much. The concept here is increasing doses of the allergen are introduced into the body via either in subcutaneous route or by the sublingual drops, resulting in development of tolerance towards the allergen. How it works? Avoid mixing extracts with strong proteolytic activity such as extracts of cockroach and fungi. They contain enzymes capable of degrading other allergens from the dust mites. Avoid immunotherapy in a polysensitized patients. Special considerations being when asthma needs to be well controlled, check and document with a peak expiratory flow rate, and also simultaneously give immunotherapy for at least 3 years. There is no improvement. If there is no improvement at the end of 1 year, you can stop the immunotherapy. SLIT versus SCIT. Subcutaneous immunotherapy is FDA approved. Patients are more compliant here because it is given in the office setup of a doctor's clinic. It is more efficacious. Higher risk of allergic reactions are common in SCIT. Whereas sublingual immunotherapy is not FDA approved. It is less compliant because patient has to take from the comfort of his house. However, it is equally efficacious and there is low risk of allergic reaction.